Good whenever you're watching this. Good morning. Welcome to week 13. We got like two or three more lectures and then we're kind of done. You got your final papers and then we're good. As we kind of wrap up, one of the things that I like to remind you is so we have this week, we got medication assisted treatment next week. I think we got like support groups at the end of the at the end, and then I give, if you want to do this one day, not teach, but I mean maybe teach, but like if you want to be a therapist one day and you want to kind of do the stuff that I do, um, the last lecture is not required at all. There are no points. There are no. It's not part of the even the. I guess it may be on the syllabus, but like it's not part of the. I mean, it's part of the class, but it's not an expected part of the class. I do that every year. I end my class a little bit early. Number one, because I know how like flooded you can be with finals, and I want you to be done with the class, and so that's part of it. But also, I take that last week for just career stuff. So the last lecture that I do will be reflections on my career, how I got to where I am, and like the thing. So one of the things that I kind of had this reflection on early on in my career was, boy, I wish someone had told me about some of this stuff. And so I extend that to students because there are a lot of things that I wish that I had known when I was sitting in your all's chair, so or couch or whatever. So that's what the last lecture will be, is just brief reflections over my career. I usually go about 45 minutes to an hour, just kind of going through the steps and what's needed and things that you that are relevant or things that you may find. But I look at it as just like a things I wish that I knew kind of stuff. So this past week was election. Tuesday was election day, and here in Kentucky, you didn't have much to vote on, but anything to vote on. But in Ohio, we had some things to vote on, and so one of them was the way that local communities work is that there are local levies that are put on for treatment, and so like your little local community your little township will have levies that are placed on or property values to to raise money for a bunch of services. And so we had two this year. The first one was for mental health and addiction. It was primarily focused for people to get addiction and addiction treatment, and basically it was going to be a couple bucks for every $100,000 of your home's value for the taxes that you pay. And then the second one was for health and human services, for children's services, to get more money than they had. So like right now, people would pay like $16 total around it, and they were asking for $23. And my math is kind of fuzzy, but $23. And then for mental health, I think it was going to be like $17 or so that would be added to your property taxes. And it cracked me up because like we said yes for mental health and addiction, which is great, but then we said no for kids. So I just thought that was kind of interesting. That I mean, obviously, I think that kids need it for obvious reasons. Like this is for the foster care system. But it was just interesting that we had, and actually this was, I didn't, this is not the actual one. This was like early. This actually did not, I didn't post the right thing here, and I should have, I'm sorry. But this measure actually did not pass. The one for the mental health did pass, but the one for the kids did not pass. And so I took this early on of just like the stark contrast, because this is winning by 19 points. I mean, that's not insignificant. And this is barely winning at this point with 33%. But then when all the vote got put in there, The one for the children's services did not pass, and the one for mental health and addiction did pass. So I just thought that was kind of interesting that that was the discrepancy and the little bit of a dichotomy. I wish that I could know why people voted the way that they did there, but that was actually really kind of an interesting thing. So it's good to see that some of the stigma, because there was a time that, like, you want money for addiction, there was this idea of NIMBY, or not in my backyard, that eventually so that would make it difficult for treatment or any kind to be built, is because by and large, if you were to ask persons on the street, do you think we should fund do you think that we should fund mental health and addiction treatment? I would say probably not 100%, because you're always going to have people like, no, let them die. But I would say you would get a healthy, like, yeah, I think that sounds fair. And we say, well, we're going to put it like in your backyard, and they would be like, no. Take those addicts and put them like in a rural, away from all of this, because we don't want them here. But then it eventually morphed into banana, which is don't build anything near anything. And that, creates trouble for access, because, like, it's one thing to offer treatment, it's another thing to offer access. And so that's important. Okay, let's talk about screening tools this week. So screening tools serve as a mechanism to direct patients towards the most appropriate form of treatment. However, patients should always have the autonomy to make decisions regarding their care. Remember, the patient is the engine of this system. And when we lose sight of that and we turn it into us, then that can create some problems for obvious reasons. But the patient should be given the respect and the dignity and the autonomy to be able to make decisions that are impactful for them and the things that they want to do. Okay. Now, as we do screening tools, if you decide to take my 450 class, hopefully you did. So that would be cool. I think signups are soon, if they're not already passed. And if you didn't, shame on you. But screening tools are not diagnostic. So the things we're going to talk about today are not going to be sufficient to diagnose. So if you decided to take my 450 class, then you'll see this again over there. However, remember this now for then. A screening tool is not diagnosis. It's not diagnostic. It's designed to get a patient to the most appropriate form of care, or to indicate a problem that they may need to do something about. Okay. So again, these are just to direct patients and get them towards the most appropriate level of care, not to diagnose them in any way. Okay. So keep that in mind, because that will be very, very important to remember. Okay. Now we're going to look at three. The first two, you'll see quite often because they are very, very prevalent. Screening, brief intervention, and referral to treatment, which is SBIRT. And then the American Society of Addiction Medicine, otherwise known as the ASAM. Okay. And then we're also going to look at the matrix model, which can be used in inpatient treatment if that's the route that you want to go. Okay. So let's look at SBIRT. So as you probably learned, everything in this field is an acronym, and this is no different. SBIRT stands for screening. Okay. So a healthcare professional administers a validated screening tool to identify the presence and severity of a risky substance use behavior. Okay, we've got a couple that we can use. The first one we'll use is called an audit, and this is just for alcohol use disorder. Okay, so alcohol use disorders identification test, otherwise known as an audit. You also have the drug abuse screening test, or the DAST. We have the DAST-10, which is the short form, or we have the DAST-28, which is the long form. Now, in most cases, the DAST-10 is going to be the most efficient. But if you have time and can do a DAST-28, and I'm going to show you both of them so you don't have to just kind of think about these, and they're on Canvas so that you can look at them and interact. The 28 can give you a little more information for you to really hone in on what's going on. But if you're just looking for a brief sort of like screening, is there a problem here? Are things going on? then the DAS-10 is perfectly sufficient for that. And then there's also the CAGE, or the CAGE assessment, which is, have you felt like you need to cut, that's the C, down on your drinking? Have people annoyed you, that's the A, by criticizing your drinking? Have you ever felt guilty, that's the G, about your drinking? And have you ever needed a drink first thing in the morning, otherwise known as an eye opener? Okay, so that is, it's for drinking, but CAGE can be used for any substance, but we talk about alcohol because it's the most accessible. Okay, so those are your screening tools. So let's look at what they actually do. Okay, so the alcohol screening questionnaire, the audit, again, this is not sufficient to diagnose. I mean, it'll give you it can steer you in the right direction, and you can get a lot of good information, but this in and of itself is not going to be sufficient to diagnose. Okay, now it's very straightforward. It's important for there's a few things here when you use one of these, and that is, if these are self-screeners. So like if a patient, if you hand it to the patient and have them fill it out, then you get what you get. If you're asking them these questions, it's important for you to let them answer. Okay, now what I mean by that is, one of the things that happens in face-to-face interactions like that, we have a tendency, and this is more of a psychological bias, to want to please or want to get approval from the person that we're with. That's a social bias. There's a halo bias in there too, but we want to get that like positive response from the person that we're with. And so sometimes when you have patients that have a hard time answering, they will say the thing that they think that they need to say to get you to either A, say okay, or B, move on. And so it's important for you to not feel the urge to fill in the gaps for them. And some of you may have a really difficult time with silence, and it's sitting in silence can be really, really challenging. And that's hard for us as humans because we want to fill in the gap, right? That silence can make us really uncomfortable. But that silence is actually really powerful, because eventually someone will break the silence, and it can be used as a powerful tool to get someone to kind of talk, right? So if you give answers here, oftentimes patients will take that even though it may not be exactly true. Okay. So for instance, how often do you have a drink containing alcohol? Okay. If I'm verbalizing this to them, they may not know how to answer that. Okay. And so they may go, well, I'll just have some drinks. Okay. What does some mean? What's the frequency? And then this is where you can say, let me give you some options, and you can give them these options. So never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 more times a week. And let them just kind of answer. Don't, you're going to have to really fight that urge to fill in that gap, because that's a human and a social thing. We have a hard time with silence, but silence can be really powerful because it allows a patient to answer. Okay. The other thing is if you throw out answers from your brain, or what it sounds like for you, oh yeah, even though that may not be exactly the case. Okay. Now, as we talk about some of these things, there's this word here, drinks. You see this a lot. How many drinks? A drink, drinks. Now, it's important to really operationally define what we mean by drinks, because a drink to me and a drink to you could be totally different things. Okay. So if I am a 12-ounce can of beer, or just lager, it's about 3.5% alcohol by volume. Okay. That is what we would consider. So a 12-ounce beer, a 12-ounce lager of 3.5, like your Miller Lights, your Budweisers, your Michelob Ultras, your standard Bud Light, like that just your standard lager, American lager, is 3.5% alcohol by volume. That is what we would consider a drink, singular drink. Okay. 5 ounces of wine. Some places would say 3 ounces of wine, but a standard common glass of wine that is filled not quite to halfway up that's your standard wine glass, that is considered a drink. In a bottle of wine, one bottle of wine is considered 9 drinks. Okay. So you can do the math there. But so a bottle of wine is typically considered 9 drinks. Okay. And then 1.5 ounces of liquor or 1 shot. Okay. So, shot glass, if I'm taking shots of whiskey or shots of gin or shots of tequila, then, or vodka, that is considered a drink. Okay. Now, here's the challenge. A lot of times patients don't just drink. So for instance, patients don't just drink Bud Light. Sometimes they'll drink some of these microbrews that can be 6, 7, 8% alcohol by volume. That's a significant difference. And so if somebody says, well, I'm just drinking a 6-pack a night, but they're drinking, IPAs that are 9% alcohol by volume, that's a significant difference than somebody drinking, 6 3.5 ounce or 6 Bud Lights, because it's impacting them in a much stronger way. Their tolerance is going to be built up much higher, and it's just a different thing. So it's important to really hone in on what it is when they say I'm having a drink. That's what that means. Okay. All right, so let's move on. DAST. So the DAST is for drug abuse or drug screening. Okay. Again, oh, by the way, we're looking at over the last year. Okay. Over the last year. Same thing here. Okay. Over the past 12 months, have you used drugs other than those for medical reasons? Yes, no, blah, blah, blah. Here's your 10. Okay. Now, again, these are not diagnostic. These are just saying this is the severity of what we're seeing, and you can present that to the patient. So down here, these are levels or stages. Like there are others about severity. If it's more than a certain score, then, there's obviously a big problem here. So you notice your scoring rubrics here. But again, these are not going to be sufficient to diagnose. As I said before, it's just giving you an idea of where someone is at and the level of severity that you're looking at. Okay. So that is the DAS-10 and the DAS-28. Cool. Let's look at brief intervention. Okay. So brief intervention is, depending on the screening results, a healthcare professional will facilitate a conversation with the patient to include feedback, advice, and motivation to change necessary behaviors. The main one that we look at is motivational interviewing, and motivational interviewing is actually very, very, very powerful. I use motivational interviewing almost every day because of how good it is. Okay. So, we have several stages to motivational interviewing. First of all, we have pre-contemplation. Okay. I have a sparkly pen. So pre-contemplation is, I don't have a problem. I don't know why anybody is telling me that I do. I don't need to change. I don't know why everybody is on me, blah, 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 blah. Now, in the stage of pre-contemplation, honestly, not a lot that you're going to be able to do, because this person doesn't see that there's a problem and doesn't see the need to change. And so despite your attempts to try to point out, well, actually, it will not help, or very rarely will it help, because in their mind, there is not a problem. So why are you bringing this up? Because I don't have a problem. I don't have a problem and I don't need to change. I'm fine. So some of this is, I'm just going to be looking to raise awareness. I'm just going to be looking to open their mind up to the possibility to present some of this to them. Not necessarily looking to change, just trying to bring to the surface and point out, hey, there could be something here. Okay. Now, eventually you wear them down, or they have something happen to where they think, okay, maybe there's a problem. Okay. Maybe there's a problem and maybe I could do something about it, but I just don't know what that is. Okay. I don't know what it is. I don't even know if it would be worth doing. So I have no idea, blah, blah, blah. Okay. So in this space, they see that change could actually be possible, and change may be something that they want to do, but they're still kind of ambivalent towards that whole process. Okay. So what we're looking to do is we're looking to just help them, what would change look like to you? Or if you were to change something, what would that mean? Or if change could happen for you, how would you go about that? What would a change in your life look like? Because we're just helping them to resolve any ambivalence that they have and choose this new thing. Okay. So you say that you want change, yet change can seem a little difficult for you. What is difficult about that change? Or what could be challenging about that change? Or what do you think your life would look like if change were to occur? Right? Talk about the benefits. So there's a number of different ways you can go about it. We're just trying to look at change talk. Okay. Look to try to help them choose that new thing. Okay. So now we're moving them into determination. Okay. Which is, I'm committed to changing, but I still don't know what I want to do. I know that something needs to be done. I know that I need to address this, but I don't quite know what it is I want to do just yet. So this is where we're just kind of gathering stuff. We're just gathering resources, helping them try to determine what is the path that they want to take and what are some of the options that are out there for them. Okay. So if we want to look at it in a different way, this is pre-contemplation. I don't want to travel ever. I have no desire to travel. I have no need to travel. There's no reason for me to travel. Contemplation. Well, travel might be nice, but I don't know. That old travel thing, I'm not quite sure where I would even want to go, or if it would even be worth it. I don't even know. Maybe it could be fun, but I don't even really know. Now we're here in determination, which is, all right, maybe I want to travel, but I don't even know the places that I'm committed to traveling, but I don't know the places that I would want to go. So I'm getting, okay, so do I want to go domestic or do I want to go international? I just want to do domestic. Okay, cool. Have you looked at Florida? Have you looked at California? Have you looked at the East Coast? Have you looked at maybe going north? Have you looked at Texas? So many different options, so many different places. Here's some goods and bads. Here's some pros and cons. Just kind of, I don't really know where I want to travel, but I'm just kind of gathering different places and seeing what I want to do. Okay. So we have found places that we may want to go. We have discovered certain places that may be beneficial for us or could be interesting. So now we're over here in action, which is, okay, now I'm going to take these steps to going. So I'm still I don't know if I really, really, really want to travel, but I'm taking these steps. So I'm booking flights. I'm booking flights. I'm booking hotel rooms. I'm booking rental cars. I'm planning activities. I'm doing things. I'm putting action into this thing behind me. Okay. So I'm taking the steps, but I haven't quite stabilized it just yet. I'm trying a few things to see how they feel, to see how they fit, and then I will judge from there. Okay. We're learning. So in this terminology, we're learning the things that we need to do. So this is where we've started maybe doing some medication assisted treatment. We've started connecting with a sober support group. We've started volunteering in our community. We've started doing a lot of different things that can be helpful for someone in their recovery process. Okay. Then we come over here to maintenance. So this is, we've made some goals. We've worked through some of this stuff, and we are just achieving things left and right. Okay. And now we're maintaining this new thing. So I have found the things that work for me, and now I am working through that. So like, what would a task here be? So okay, so you have found some things that work for you. What would be something that, like, of these things that you've done, what have been the most important things for you? Or of the things that you've done, what have had the most impact in your recovery? Or as you think about what your future in recovery looks like, what comes up, kind of thing. Okay. And so then that moves us into this maintenance thing. And this is kind of where people will exit the loop because they've completed all the tasks. But then sometimes you can have a recurrence or a relapse, and that's okay. There's a common mantra within the recovery community that is relapse is part of recovery. Not necessarily. Not everybody's going to relapse or have a reoccurrence, but sometimes it happens. And so this is not like a linear thing, so it doesn't go from step to step. You can have somebody that goes from 5 back up here to 1 and be like, you know what, this is all just kind of tiring. Or they can go from 5 to 2 or 4 to 2, or they can go from 6 back to 3. Okay, it isn't like a linear thing. We can jump in and out of this place at any given time. And so again, we don't want to shame, we don't want to blame, we don't want to be like, what happened? We want to just kind of sit with them in that mess, and that's okay. They had a reoccurrence. We can help them get right back to where they were before. Okay. So again, listening for change talk, and again, using those ORs, open-ended questions, affirmations, reflections, summary. Like, you tried really hard on some of this stuff and it didn't seem to work. So what are some things that you could do differently this time? Or what would you wish that you would have done differently? And that's important. Okay, cool. Goals of brief intervention is just education, okay? And increasing their awareness of the consequences of substance use, kind of talking to them very bluntly, very directly, motivating them towards changing, and then also assisting them to make choices that reduce the risk of substance problems. Okay. So if someone is using and thinks that they do not have a problem, you can talk to them about safe levels. Okay. If you want to use recreationally, here's a window of tolerance. This is what you really need to watch out for. We're not shaming them. We're not judging them. We're not blaming them. We're saying, okay, this is where we're at. This is how we can treat. Here's how we educate. Okay. I've had a patient, who basically told me that they were going to go use heroin, and like, in treatment, in therapy with me, tell me I'm going to go use heroin. And they were very matter of fact about it. And so I could sit there and try to fight them on that, or I can choose to build that relationship and say, okay, obviously I cannot advocate for that. I cannot tell you that I think that's a great decision. However, if this is what you're going to do, what are you doing to keep yourself safe? What are the protection mechanisms that you have around you to make sure that you're okay? Do you have a Narcan? Do you have a phone number that you can call? Do you have these resources that can help you to stay safe? There are phone numbers that will sit with you while you use, and to make sure that you're okay. In the event that you have a medical problem, they will talk to you, they will sit with you, they will walk you through it, and they will, if you go unresponsive, then they will call for help and get somebody there that can help you. Okay. So we don't judge. We just sit with them in that difficult space while they go through their recovery process. Okay. Ways to go about it. Again, raising the subject. This is in the brief intervention stuff. Just providing feedback. So for instance, if you're in a medical facility and there's a drug screen, just reviewing what that screen is and the connection that, your liver enzymes are really, really high. That's kind of indicative of liver damage. You know, could it be connected to your drinking? Do you think? How's that going? And trying to just build those connections, looking to enhance the motivation, right? So determine their readiness to change. Where are they in that change wheel that we talked about? Try to develop some of those discrepancies, and then discussing pros and cons. Okay. And then also negotiating. Every relationship that we have is in some ways a negotiation. So what is our goal, right? Is there a space for advice? We don't always give advice, but if they're saying, how can I'm going to use, or something I can stop, what, there can be, that's a space for advice. Summarizing, handouts, giving them something tangible that they can take with them. And then talking, talk to your primary care doctor, and then make sure that you're being very appreciative of them showing up, because that's a big thing they could have hidden. Finally, let's talk about experts, or the referral to treatment. All right. So, the ERT, or the ERT in this. So we have 6 that we look at. We have outpatient, which is just your standard sitting in an office setting and just talking about stuff. Intensive outpatient, otherwise known as IOP. Now, IOP is going to differ based on who's doing the billing, really. What if you take insurance, and insurance is one of your primary modes of payment, they kind of set the rules oftentimes for what you're going to get paid for. There are a lot of private pay places, or self-pay places, or places that do not take insurance, that call IOP something very differently. But when you're talking to professionals, IOP tends to be 3 hours a day, 3 days a week of group therapy. Some places will do 5 days a week for 2 hours. That is also appropriate, because what the Center for Medicare Services, or CMS, who kind of sets the rules for some of that stuff, defines IOP is at least 9 hours of therapy in a group setting per week. Okay, so 9 hours of therapy. However you break it up, it's up to you. But most will do 3 days a week for 3 hours. Others will do 5 days a week for 2 hours, but it's 9 hours a week, however you want to frame it. Partial hospitalization, or PHP, which is you'll go to a hospital and or a care facility, and you'll be there basically all day. So you'll check in at like 9, and you'll have a whole day's worth of activities, and then you'll leave at like 4. And there's a whole different variety of activities that one can do. We talk more about this in my 450 class, but it's a way for people to get a whole lot of services in a short period of time. And it usually lasts for about 2 weeks. So these are people that have a very acute need for stability, and they can't really commit to doing a full residential detox or an inpatient. So they will do a partial hospitalization, which will give them something to do during the day. But let's say that they have to take their kids to school at like 8, and then pick them up at 4:30. Well, but they're afraid of what they're going to do during the day. That's what PHP will allow them to do, is have a place to go for a couple weeks and get better. You have simple detox, which is about 3 to 7 days. Most of your substances, methadone could be the exception, but most of your substances can, after about a week, you are fully through your withdrawal. And that can take, 3 to 7 days. Then you have residential detox, which is 28 days of kind of full residential treatment. And then long-term residential, which can be up to 1 year, depending on the place you go and the money you have to spend. All right. So how do we get there? Well, the ASAM will allow you to do that. And I could not find a non-blurry picture that looked good. So this is the blurry one, but there is one on the Canvas shell for you to check out. Get comfortable with this. You're not going to, this may come up again in a quiz. I don't know. But if you did decide to take the 450 class, you're going to see this. And this is going to be part of what you do for the treatment write-ups that I have you do. Okay. So basically what this is this is called a crosswalk. And so we have 6 dimensions. Okay. And I'll talk about the dimensions in a second. And then we have levels of care that go along with that. So what you would do is you would say, okay, we're here in dimension 1, acute intoxication or withdrawal potential. So the patient presents to you, where are they? Right. So if I'm in just a level 1 outpatient, they're not experiencing withdrawal or minimal risk of withdrawal. And this is manageable at a level 1, just standard outpatient, all the way down here to medically management. So like high risk of withdrawal and needs a level 4 withdrawal management and the full resources of a licensed hospital. So this is, they've been using heroin and continue to use heroin, and they're going to need medication intervention if they decide to get treatment. So they would be a level 4. They need medically managed intensive services. And you would do that for each one. And what that does is it gives you like 6 different dimensions, and then you look at it and say, okay, what is the most appropriate level of care for where someone is at? Okay. So here are the dimensions. How likely are they to use again or go through severe withdrawal? That's your acute intoxication. Number 2, what is their biomedical condition and complication? So what's their health history? Dimension 3, emotional, behavioral, cognitive condition. So how's their mental health right now? Dimension 4, readiness to change. Are they ready to change? Are they ready to make that commitment, or are they generally ambivalent? Dimension 5, relapse or continued problem potential. Is this a common reoccurrence for them? And then number 6, what is their recovery or living environment? What is their living environment? So like if they go back to their home, are there people in the home that still use? If so, that's a big, maybe they need residential. But that's also one of the complications that happens, and this is just the reality of it. People wonder, will they get treatment? Why do they keep coming back? Well, let's say they go to 28 days of treatment. Well, in 28 days of treatment, you make a ton of, your life can really start to feel a little bit different, not completely. But you've had a therapist with you to talk about all your problems. You've had other people, a social community that you've connected to. You've had people that care about you. You've been generally isolated from your family stressors or the things that are going on. And it's just been you've been able to, I don't want to say take a break, because that sounds not how I want it to sound, but you kind of have been able to take a break from like the stuff that's been stressing you out. And then at 28 days, we say, okay, you're better, go home. Well, we send you right back into the environment, and you don't have the same level of coping skills and the same level of support that you had. And the environment is generally not conducive to recovery. And we wonder, you realize you had a return to use, right? And it can really beat somebody down, kind of like how Kentucky beat down Florida last night in football, which was great. And I say that because your code word this week is Florida, but it can really beat somebody down. And so the likelihood of them wanting to get treatment or wanting to seek treatment could be very difficult. So that's why we look at a lot of these dimensions, because it really helps us to hone in on what is the best thing for the patient. The other thing to keep in mind is we want to try to put a patient in the least restrictive form of treatment that can address the problem at hand. Okay. So just because somebody is, I've done things called Casey's Law, which I think we talked about earlier, but I've done Casey's Law assessments, and I would have moms and dads that would want their 15-year-old taken to residential care because they're smoking marijuana. Like, come on now. And so like that is not the most appropriate form of treatment. We want to look at what is the least restrictive form of treatment, to get a patient to that will address the problem. Okay. And then finally, the matrix model, which takes a little bit of everything. We see this in residential or inpatient treatments, where they try to do a little bit of everything. So cognitive behavioral therapy, having family therapy, using that motivational interviewing, contingency management is basically kind of like the little rewards that people can get. And that can vary from person to person. But the way in which we did it at Journey Recovery Center for a brief time was that we would give patients, it would start out with we'd have a restricted debit card that they could take to get groceries or whatever they needed, buy gas. But on their first, like they come to treatment and they do a drug screen that's appropriate and they get $5. Well, the next time they do it, and it's the same thing, they get $7.50. And it just builds up. This streak builds up over time to where eventually every time they would come in, they would get $25. And over the course of their time with us, over the course of like 6 months, it would equal out to about, I think it was like $800. No, it was $600. It was $650, because at $651 you have to put that on the taxes. So it all equaled out to about $650 they could earn for doing recovery stuff. Now that's just one option. There are others that would do like they would have like a store that someone could come in, that someone could get like shampoo and some clothes and like little toys for the kids or whatever. So that's another way of doing contingency management. So there's it's basically like rewarding someone for recovery. Okay. And then also the 12-step facilitation and community stuff. This is the matrix model. Again, it takes a little bit of everything and kind of throws it all into a big pot. It actually works really well. It's really good. Last thing I'm going to mention is a siloed healthcare system, and this is something that is really important to think about. The way in which a lot of this stuff works is like our healthcare system. Everybody has their little silo, so none of these systems talk to one another, and that's where some of these screening tools come into play. Is because, like, for instance, with this first part of the expert, like this stuff could happen in a primary care office, and it actually is designed to do in a primary care health office. But these systems don't talk to one another, and so patients get really frustrated when they go to one thing and then they say, okay, well, you need a referral to go somewhere else, and then they go to that somewhere else and like, well, no, we've not talked to that other person, and they go like it's just these systems don't talk, and because of that, patients things fall in between the gaps. So that's where some of these screening tools can really be effective, is because it helps to kind of do away with some of that siloed healthcare system that is not great for patient care. Where I'm working in Newport, we're trying something kind of different, which is in the same building we have primary care, we have addiction, we have behavioral health, we have pharmacy, we have a nutrition dietitian. We also just got podiatry in. So we've got like 8 different service lines. We also have a care nurse. So we have 8 different service lines all in the same building. That's pretty cool. So a patient can come into one place and all of these systems are talking together. And I'm really proud of the work that we're doing right now because everybody's talking to one another. So I get referrals from the primary care doctors. I go back to them to talk to them about if patients got struggle with addiction or mental health or whatever. Like I'm going back and giving them that feedback, and we're talking, and it's better patient care. So that's what a lot of these systems are designed to do. I think that's all I got this week. So as always, Canadian geese are definitive proof that evil exists. Live mahalo. I will see you next week. Okay, bye.